A very good evening to all my viewers. So today let's discuss about a very interesting topic of OASIS. OASIS stands for Obstetric Anal Sphincter Injuries, and let's today learn about its definition, its classification, what are its predisposing factors, the causes, the clinical presentation and its management. Hi, this is Dr. Sonali Jagati, Senior Resident Obs and Gynae Department at SCBMCH Cuttack, having secured an All India rank of 3546 in NEET PG 2021. So how do you define OASIS? OASIS, or the obstetric anal sphincter injury, is defined as the disruption of the perineal body with the division of the anterior part of the anal sphincter with the loss of the distal portion of the rectovaginal septum. Before going into the depth, first understand the pelvic floor anatomy. Now here I will be discussing only the relevant anatomy for OASIS. Maybe in some subsequent session where I'll be discussing about the prolapse, there shall be highlighting on the anatomy of the pelvic floor along with the supports of pelvic floor organs in detail. But here you should just understand that what are the muscles which are involved in the pelvic floor and in OASIS. So this you can see around the vagina. You have the bulbospongiosus muscle. This is the bulbospongiosus muscle. You have the superficial. You have the superficial transverse perineal and the deep transverse perineal. Then the external anal sphincter is here. Around it you have is the pubococcygeus and the ileococcygeus, which together form the levator ani. Last is the coccygeus. Okay, so this is very important to understand, because routinely when you are giving an episiotomy during vaginal deliveries, it's very important to understand what are the structures that you are cutting. So obviously you are cutting the vagina. Along with that, you are cutting the bulbospongiosus muscle, which is right around it, surrounding it. Okay, then you have the superficial and deep transverse perineal muscle and the levator ani, which is composed of the pubococcygeus and the ileococcygeus. Remember, these pelvic floor muscles converge and they join here to form the perineal body. So when we are discussing about the OASIS, by definition it is when this perineal body gets disrupted and the external anal sphincter anteriorly also gets disrupted. So this portion is disrupted along with the loss of the distal portion of the rectovaginal septum. Okay, so between the vagina and the rectum you have the rectovaginal septum, which is also lost during injury in case of OASIS. So let's discuss about the perineal tear first. We have 4 degrees of perineal tear. First degree involves only the skin. Second degree involves the perineal muscles, as I showed you the perineal muscles. And episiotomy is a surgically planned incision which is given, and that comes in the category of second degree. Third degree is when there is partial anal sphincter involvement, and fourth degree involves the rectal mucosa. So let's learn in depth about this classification. It is known as the Sultan classification of OASIS, named after Sir, who is pioneer in studying in, and has given great contribution in the field of OASIS. So let's learn about the classification. So as you can see, first degree means there is only vaginal epithelium or the skin is involved. Second degree means along with that there is a perineal muscles are being cut. Third degree is the tear of the anal sphincter. Okay, it is further classified into 3A, B, C. A is less than 50% of the external anal sphincter. 3B is more than 50% of the external anal sphincter. 3C is where the internal sphincter is torn. Fourth degree is when the anal mucosa is also involved. Remember that only grade 3 and 4 come under OASIS. Grade 1 and grade 2 are not a part of OASIS. And episiotomy is grade 2 type of perineal tear. The risk factors. So risk factors can be divided into maternal risk factors and fetal risk factors and intrapartum risk factors. Maternal risk factors include nulliparity, extremes of age means too young or advanced maternal age. Also, ethnicity like Asian ethnicity has been shown to cause predisposition to OSS. Also, shortened perineal length, like less than 25 is again a risk factor. Nulliparity, vaginal birth after CS. So, these are some maternal risk factors. Now, what are the fetal risk factors? You can say that fetal weight more than 4 kg, that means macrosomia, is again a big risk factor. Shoulder dystocia, occipito-posterior position, these are the fetal risk factors. Then what are the intrapartum risk factors, that is during delivery? If the most important one being instrumental delivery, then giving midline episiotomy, any induction of labor, it may be by oxytocin, and giving epidural analgesia which may prolong the second stage of labor. So these are some of the important risk factors for OSS. Let's learn into the causes. Now, obstetric causes I have already highlighted. Next is any traumatic causes. Now, this can be any sharp or blunt object injury. Sexual violence can also lead to OSS, especially in the extremes of age, less than 20 years or elderly women. Then surgical trauma, very important. If she has a past failed surgery of anal canal or perineum, or which she had any previously failed perineal tear repair of third and fourth degree. So these can again lead to a OSS in the subsequent delivery. So, what will be the clinical presentation? Always remember that the fetal incontinence is the main symptom of OSS. But again, this depends on the extent of damage that has occurred to the external sphincter. So, if it is a mild degree, okay, then she may only complain of loose stools. But if it's a major degree, then she will tell the passage of even hard stools with incontinence, and also there is incontinence to flatus. So this is how you will grade or assess clinically from her symptoms the degree of anal sphincter injury. So, how do you evaluate it? Look for the local signs. There will be pain, there will be redness, the perineum will usually be absent, the red shining mucosa of the anal canal and the rectum, and of the anal canal and the rectum, and the pinkish vaginal wall will be together, and there will be hardly any perineum in between. That means the perineal body is disrupted. Okay, and also you need to look for the radial folds of the skin which are usually present around the anal sphincter, that also will be absent. Remember, it's a very, very important advice that all our seniors give, and we should do it routinely after every vaginal delivery, irrespective of whether injury has happened or no. Always do a per-rectal examination before you come out after doing the delivery or after repairing the episiotomy. So this ensures that you have ruled out any anal sphincter injury. Okay. Next, per speculum, you should look for the condition of the vagina and cervix. Also, you can do a vaginal examination to look for the cervix and the uterus. Digital rectal examination is the most important thing, where you will see that there will be no gripping sensation because the sphincter is toned. Before going into the repair, let's understand how do you prevent it. So, prevention is by, very important, giving a mediolateral episiotomy. Okay, so always remember that in current obstetric practice we always prefer a mediolateral episiotomy over midline episiotomy, because we can see that if by chance this extends, it is straight going to enter and tear the anal sphincter. So it's very important that you give a medial lateral episiotomy. This is 60-degree away from the midline when the perineum is distended. Also, always give a perineal compression or perineal support when the fetal head is crowning, and this also helps in preventing OSS. Warm compression during the second stage of labor is always advised, and proper conduction of delivery by monitoring is advised, so that we prevent any obstructed or difficult instrumental delivery. Next, what is the timing of repair? Remember that timely diagnosis is very important. If you have diagnosed it on the delivery table, that is intrapartum or early postpartum, then that is within 24 hours of delivery, you should repair it that time itself. If it is not diagnosed within 24 hours of delivery and she is referred to as late or she comes later, within then at 3 months you should repair it, because at this time the infection, the inflammation would have subsided. So if after 24 hours she comes, you have to repair it at 3 months. After 6 months, it becomes very difficult to repair because all the scars have healed and they would have really become dense. So it becomes repairing very difficult. Okay. So what are the pre-operative management that you have to do? So you have to give her a low residual diet or liquid diet for at least 2 days prior to surgery. Local hygiene should be maintained, do betadine toileting, and you can also give her antibiotics 24 to 48 hours prior to surgery, so that you control the intestinal bacterial flora, and bowel should be preferably emptied prior to the surgery. So what is our aim? Aim is to restore the continuity of external and internal anal sphincter and construct a thick perineal body and the rectovaginal septum. The aim is to construct a muscular cylinder which is at 3 centimeter long and 2 centimeter thick. Also remember that after you perform the complete procedure, you should always do a digital rectal examination to ensure that the sutures have not inadvertently tied the rectovaginal mucosa. The principles of repair, very importantly, this procedure has to be done in OT only, and it has to be done by a skilled senior gynecologist. It can be done under regional or general anesthesia. The repair is always done in a cephalocaudal direction, that means from top to bottom approach, so that uh, top structures are not obscured during repair. Also remember that after you have finished the repairing procedure, always do a digital rectal examination so that you ensure that the sutures have not accidentally tied on the anorectal mucosa. So coming to the sequence of repair, as I told you, it has to be cephalocaudal. So first you are going to repair the anorectal mucosa. So this is done in continuous non-locking type of sutures. Remember, this can vary from surgeon to surgeon. But sometimes some textbooks also write as interrupted stitches can be given and the knot will be towards the lumen. 3040 Vicryl is used. Then next you have to repair the internal anal sphincter. The internal anal sphincter, when it tears, it just tears and it runs laterally and upwards. So you have to bring it together and you have to stitch it in interrupted vertical mattress fashion. For this you can use again 20 or 30 Vicryl, or monofilament PDS can also be used. Next comes the external anal sphincter. Now this is where the debate lies, that whether you have two techniques basically, end-to-end and overlap technique. So many have this debate or confusion as whether it has to be done end-to-end or overlap. Remember, surgeons have their own style, they can have their own preferences, but it is said that when it is a partial thickness tear, it is better to use a end-to-end technique, and if it is a full thickness tear, you can use a overlap technique. So for this again 20 Vicryl can be used, or 30 monofilament PDS can be used. Okay, for full thickness you can use any of these, whereas a partial thickness end to end is better. This is a end to end repair, and this is where it is a overlap technique. Okay, so this is what we use for external anal sphincter repair, right? This image over here, it is showing the anal ultrasound. Okay, so you can see that in this ultrasound, which is put transrectally, and it helps us to assess the defect of the external anal sphincter and the internal anal sphincter. Okay, so this can also be used in the diagnosis and to assess the degree of sphincter involvement, right? Next, what is the post-operative management? Of course, you have to give her broad-spectrum antibiotics. Then catheter can be kept usual up to 24 to 48 hours. Analgesics have to given. Then she has to be kept NPO for at least 24 hours, and then start on a liquid diet and slowly increase the diet. And you have to give her stool softeners, and bulking agents are not routinely given, but you can give her laxatives or stool softeners. Physiotherapy and pelvic floor exercises can be started 6 to 12 weeks after the repair. Follow up after 6 to 8 weeks. Again, you have to ask for a detailed history of any anal incontinence. Do you have to do the inspection of the perineum and continue the perineal exercises? Now, very importantly, regarding her future pregnancies, if she was asymptomatic or she had a very mild degree, then yes, she may be offered vaginal delivery in her future pregnancy. But if she was symptomatic or she had a history of prior repairs also, then cesarean is the most preferred method for future pregnancy delivery. So I hope that in a nutshell I have tried to clarify what is OASIS and the most important aspects of this very important topic. Now, this has been asked in various forms in both the PG entrance exams as well as in MS exams, and it's a very, very important topic. If you want to know more in detail about how the surgery is done, I think it's available everywhere online, so you can go and see the surgeries, how exactly the anal sphincters are being repaired. It's a very interesting topic, and I hope if you have any doubt, then feel free to write in the comment section, and I'll be glad to clarify. Thank you and have a great day.